would I have had these opportunities if I was in Adelaide? Would I have been so fortunate? And I don't know if I would have, because, Steve often says that. He said, Broken Hill, you can be whoever you want to be here.
Meet Heather Pearce, the CEO of Thrive Medical and an occupational therapist. She is a visionary and problem solver who works with others to achieve outcomes for regional people. She is today's guest on A Home in the Outback, an independent podcast about people living, working and creating in the far west of New South Wales. I'm your host, Catherine Waite. Heather was born in the small town of Cleve on the Eyre Peninsula in South Australia and grew up on a farm. She went to boarding school and then university in Adelaide and studied occupational therapy. Her first job out of university was working in the return to work field, which she really enjoyed. After a brief stint working overseas, she moved to Broken Hill in 2010. She saw there was no return to work consultants in town and set up a business. Over the years, it's morphed and changed to respond to the needs of the town. However, after she connected with local businessman Steve Radford, she got the courage to step out and purchase an MRI machine and open Thrive Medical in 2021. Heather speaks to the ongoing challenges and specific needs places like Broken Hill have when it comes to providing health services. Along her journey, she provides advice and reflects on how someone from away can build a life in Broken Hill. Well, Heather, thank you for taking your time to chat to me today a little bit about your life. Let's start from the beginning. Where were you born and raised?
Hi, Catherine. I was born in a Cleve hospital, which is on Eyre Peninsula, and I grew up there until I went to boarding school in year 8. My dad was a farmer, my mum was a teacher, and I follow all these people on Instagram about, lifestyles that are self-sufficient, and I reflect back and ours was very close to that. It was lots of time outside, and my older brother and older sister, we had sheep and cattle and grew a lot of vegetables and ate our own meat, and had a really close network of friends too, which are still important to me today.
Sounds like it was a really lovely childhood.
It was a great start. I'm very fortunate to have had, and I think a lot of my work now, we're exposed to people who haven't had the start that I did, and I think it's one of the biggest forms of privilege is growing up how I did.
What was it like moving to Adelaide and going to boarding school there?
Yeah, that was interesting. So I think because I was the youngest, and my older brother and sister had gone away to boarding school, so it was just mum and I for some time. And she was older when she had me, so neighbours would drop in, but it was quite we were by ourselves for most of the day. And then to go to boarding school where you're with 6 people in a dorm and you're around people all the time, it was a bit of a shock, I guess. But schooling wise, the opportunities that I've had since then, I don't think would have perhaps been possible if I didn't have those opportunities. So and met some really lovely people too who are still in my life today.
So what did you study at university?
So when I finished year 12, I went straight into university and studied occupational therapy. I really didn't know what OT was at that time, but I had an older cousin who had chosen that as her study pathway, and she really enjoyed it. So I got a similar score to what you needed, so I thought, that'll do. So I've been so lucky that I actually love the job that I sort of randomly chose.
OT, occupational therapy, brief summary for someone who doesn't know anything about OT, what would you say it is?
I would say it looks at the things that you want to do, but for whatever reason you can't quite get there to do them. And we look at what the barriers are and try to come up with solutions to help with activities of daily living. So that can be so different, I guess, for someone in a wheelchair after a spinal cord accident, or if it's a child who has poor fine motor control that can't do the shoelaces. I guess the setting and the people we work with is really variable, but at the end of the day it's trying to get people back to what they want to do.
So what was your first job after university?
So I at that time, and sorry I'm backtracking, but at the current market for OTs, it's really hard to find OTs to employ. But at that time, I think there were about 10 of us who went for a new graduate job in Port Augusta, and I wasn't successful in that. So I thought, how am I going to use this 4-year degree? And I was living in Adelaide at that point in time, and a job came up with the Department of Education and Children's Services, and it was as a case manager or return to work consultant. And you could either have an occupational therapy, social work, psychology, physiotherapy background, or nursing actually. And I thought, that'll be fine until I find a specific OT job. And I really had no idea what I was getting myself into. But I guess I stayed there for a number of years, and throughout that time, even though to be honest, I was pretty rubbish to start off with, because I had read the legislation, but I didn't understand it. I didn't understand how it applied to these people's situations. And, I was young, I was 20, 21, and working with people, teachers who, were probably teaching me a number of years ago. And, teachers are, their job is to be in charge in front of the class. So, having someone like me trying to tell them what to do was rather challenging.
But you really enjoyed it?
I did. Actually, I ended up finding, there were so many reasons, I think, with, and that was particularly with the workers' compensation system. There's so many reasons why someone at that point of being referred to me were off of work. They could have had a very significant injury, so they were still in that rehab pathway. They could hate their boss. They could have really fixed views about pain that they thought that they couldn't do anything until the pain went away. They could want to transfer, and that was their motivating factor. So I guess being a bit of a detective and trying to come up with solutions, I really loved that part of the job. And I've worked out, I guess from growing up in the country, and I had some pretty ordinary uni jobs, but I'd learnt to build rapport with people and to get them to trust you. And I think once you do that, you get a lot more out of the people that you're working with. So it actually got a whole lot easier because I had those foundational skills, I think, from the jobs and from the upbringing that I had.
So you do this for a couple of years, in this kind of return to work field, and then somehow you find yourself moving to Broken Hill.
Yes. So my husband at the time and I had a bit of a deal, and by this time I had a 2-year-old, Cameron. And I really wanted to go and work in the UK and see a bit of Europe, and Ryan at that stage didn't really. So, I suggested that if we moved to the UK, then I'd move back to Broken Hill with him. So we lived in the UK between 2007 and 2008. And then we moved back to to Adelaide actually, and I'd had Harrison, our second son, and his father wasn't doing well health-wise, and had a family business. So at that point, Ryan said, "Well, is it time? Should we move back to Broken Hill?" So in a roundabout way, I certainly didn't think we would still be here 13 years later, but ended up there and still enjoying living here.
And so you worked at the hospital for a short time, but you then found yourself back in this workplace or this field of return to work. So how did that happen?
Yeah, interestingly. So, I think, hats off to people who work in the hospital system, because, there's some amazing people who do a great job in that environment. For me, I felt a little bit like a square peg in a round hole. I didn't know where I fitted. And there was someone who rang, it was a rehab company, and they were looking for a local OT to contract to them to do some assessments. And they said, "Do you know anyone?" And I said, "Ring me back after 5 on this number." And that's where it all really started. It was an opportunity that came up. I'd had an ABN from doing some private work in Adelaide, and I thought actually there's such a scope for this to be offered privately, because at that point in time there weren't any other private allied health service or occupational therapy services.
In Broken Hill?
In Broken Hill, yeah.
So it was a real niche. And so how did that turn into a business? Because you've grown, talk to me about that process of the number of businesses you've had now.
Yeah, and it started, it's rookie mistake. We started with a very long name of Outback Occupational Therapy, which every time you pick up the phone you don't want to be reproducing that. Thrive's much better. But another OT and I, she saw the need as well, and we decided to go into private practice together. So about a year into that though, she wanted to become, or she wanted to change in direction from being an OT, so she joined and became a paramedic. And I said, well, I really want to give this a decent shot. So in that year though, we started with the Department of Veteran Affairs. So anyone who's been to war gets a gold card, and they're able to access services for equipment and for home modification. So that was a lot of our work, and also mining medical, so functional assessments when people were going for a job on the mine. We started doing those at that point in time too. So I guess after that year of doing them, I just went, there is a lot more, but this is just the tip of the iceberg really. So we bought I bought an older residential house in Morgan Street, and we turned that into, I guess, a bit of a clinic, and that was probably 3 years down the track. We went from Outback to Interhealth was the brand of our new business, and it just started off with myself and another occupational therapist, and then within a few years we had a physio, a speech pathologist, and we were doing a lot of these medicals. So it requires a functional assessment, a hearing test, a spirometry test, a drug and alcohol test, sometimes a chest x-ray, a lead test. And in talking to employers, they were frustrated that there wasn't one spot that they could have all those tests undertaken. So I had a friend, John Wenham, at the time, who he used to walk past the practice, and I said to him, would you think about coming in and just seeing these people that they just need to get signed off? We've done all the other work with them. And he said, sure, that's a good way to start. So, and then within 6 months, he said, well, let's see if there seems to be a need here. I'll give it, all my mornings. So I'll give it, 5 mornings a week. And then, within another period of time, we had Dr. Victoria Bradley joined us, and Dr. Crossman joined us as well. So we had, this medical and allied health team working out of this tiny space, which we look back and think, I don't really know how we did that. But I think it grew organically because we had the right team, and it also grew organically because the need in the community was there, and that was what we were responding to. I think often people come to Broken Hill and they sort of try and do it top down, whereas if you do it from bottom up, you're getting a really good understanding of what people are going through and on how to fix the problems that they're having.
A couple of years later, you find yourself with an opportunity to meet Steve Radford. And now most people would know who Steve is in town, but if you're new to town and you're listening to this, who is Steve Radford? Yeah,
so Steve lives and breathes Broken Hill. He has this saying where he says, you're either from Broken Hill or you wish you were. His grandfather was one of the, Les Radford was one of, I guess, the primary people in building the town. And then Gary Radford, who is Steve's father, was probably the biggest employer in town for a number of years. And Steve at that time, owned Consolidated Mining and Civil, Basin Sand Logistics. He also owns Porsche Gold Mine, and since then he bought the Broken Hill pub. So he's got, he's an astute businessman. And often when I'm describing Steve, if you look at your iPhone and you look at, just the photo lens and you just see this bit, and then you go on that panoramic setting and it makes you go around a whole 360, and that's what Steve does. He looks at all the bits and sees how they're all going to go together. And I guess for Steve, what he was frustrated with was, trying to get people to come and work in Broken Hill. If you don't have medical services, then that's pretty important in terms of trying to attract people to Broken Hill. And then the other side of it was his father, Gary, had been unwell probably the 12 months before we really went into business. And, all these things that Gary needed, like an MRI, weren't available in Broken Hill. And Steve in Steve's way was just like, well, we'll just buy one, we'll buy this. And I said, do you know how much they cost? They're like $1 million. You need this chiller unit thing, and you need a radiologist, you need a radiographer. And he said, oh, well, it's cheaper than a bulldozer or whatever piece of equipment they use in their mining world. So I think for Steve, his motivator was, for his family and for him who lives in Broken Hill, he wanted these services to become available. So Good Friday, I was going to the gym, which was run by Brock Martin, and Brock had done his apprenticeship with Steve. And he said, did you want to meet Steve? And I said, yes, please. So we'd actually tried to put an MRI in previously at Shop 10, which is in the Coles complex. And what we'd done, because of the overhead costs of it, we'd put a base grade MRI in. It wasn't successful because I guess if the surgeons are looking at that as to, should I operate or not, they want the image to be top notch. And what we were producing was not top notch. So, and we were limited to what we could do. So we couldn't do contrast, we couldn't do any organs, we couldn't do brain. So yes, we identified there's a problem. We tried to find a solution, and it didn't really fit the mark. So that was the sort of point where we met with Steve, and Steve's like, well, let's if we're going to do it, let's do it properly. And he said, well, he'd already purchased the old Legion Club, which is where we're situated now, and he said, let's refurbish this and turn this into a comprehensive allied health, medical, imaging, everything in one spot practice. And I just went, righto, let's go. So, it wasn't always that smooth. To be honest, it was a bit bumpy because I guess after 10 years of building something, you take it pretty personally, and we had a few speed bumps along the way. But if I reflect back, what Steve really gave us was an opportunity to expand something that I didn't really even see how big it was or had the potential to be.
So you're effectively business partners now.
Yeah, so we're shareholders in Thrive, and I'm an 80% shareholder, Steve's 20%. And Steve, we have an advisory board which Steve sits on, and he's there, I guess, when I need him to say, what do you think about this? But he's pretty lets us go with the day-to-day operational management of the business.
What is an MRI machine, and how does it differ from a CT machine?
Yeah, so just keep in mind that I'm an occupational therapist, not a radiographer, but in layman's terms, it's like a ginormous magnet that there's helium gas that makes it run, and that helium gas has to be kept at a certain temperature so that it can operate effectively. It's different from CT. Things will show up in an MRI that won't show up in a CT, so it's considered the gold standard for imaging.
What's it used to kind of scan?
That's a really good question. So there are so many different types of MRI, which I certainly didn't know about. There's musculoskeletal type, so knees, hips, feet, anything relating to joints. There's organs, so a brain. There'll be a contrast MRI, so they put contrast through and can see where it's going in the body. So there's like the endocrine system, there's prostate, there's breast. There's so many different types of MRI that can be completed. Sometimes there are additional coils and things that are needed to do certain ones which we don't quite have yet, and they have to be referred on to Adelaide.
So is it mostly used in preparation for surgery or diagnosis, or? Yeah,
usually what will happen is someone will see their doctor, they'll do a clinical examination and say, oh, okay, your knee's giving way, it could be a cruciate ligament. Then you'd have the MRI to really see what's going on inside. Sometimes it's used throughout a process. So, for example, if someone's palliative, it will be used at certain points to see how a condition is progressing. Main use is diagnostically, though.
So, before the MRI was here in Broken Hill, what would a patient have to do?
Yeah, often they would be, have a CT, and then they would make a diagnosis without all the information that you would have in another location. Alternatively, they would fly them out. So for things like a suspected stroke, we do a lot of inpatient work with the hospital, so they'll transfer them here, we'll do the scan, they'll go back to hospital. So now they can really diagnose that without having to fly them to Adelaide, which is fantastic. for, I guess, knowing what you're dealing with and being able to treat it accordingly.
And I guess the question I had was, why hadn't the hospital put in an MRI before now?
Yeah, that's a really good question. So I guess going back to it needs to be kept really cold, and we live in it's a balmy 39 degrees out there today. So I guess logistically it can be considered a bit high risk. I think, it's quite a large machine. There might not have been space to put it. And also we've got between 19,000 people. So I think why Steve and I wanted to do it is because of our remoteness. Yes, we can go to Mildura, but you're looking at other people like Whitecliffs and Wilcannia, and if it's not here, then it's an additional however many hours that they have to travel. So I think it's a combination of, was there enough volume for it? At that point, there was no, you couldn't bulk bill new MRIs without it having a provider number, and probably the servicing and maintenance costs. And they're extortionately expensive to get. Or actually, I say extortionately expensive, it's probably like a quarter of a Sydney house, but they're an expensive piece of imaging equipment that requires pretty frequently they need to be serviced pretty frequently, which is a large cost if you're not getting that volume out of it.
And I understand there was a change in how, I guess, imaging services happened with MRIs during COVID, that Steve and yourself had a part to play in that. Can you talk me through what the issue was and what happened?
Yes, absolutely. So when we first looked at, Steve and I were first discussing it, and I was telling him, I guess, all the reasons why we shouldn't do it, and one of them was because we didn't have a provider number. So what that means, I guess, I'm a health professional, I have a provider number, so if I see a patient, for example, someone with a gold card, like a war widow, then I can bill Medicare for that service. With imaging equipment, it's actually assigned to the piece of equipment, and the government had put a freeze on all new MRI provider numbers, so there are only the existing provider numbers in the system. So what that meant is even if you put a new MRI in, like we did, you couldn't bulk bill for things like that Medicare had items for, which I was worried about, and Steve kept saying, build it and they will come. People were paying out of pocket, so we were charging $260, which is actually quite reasonable. That was like to break the break-even point, but people were paying that instead of having to travel. And I guess with that information, and with Mark Coulton came numerous times to see it, he was able to see that there was the need here locally and push that further. And what resulted, and I guess also having COVID and people not being able to cross the border, it really showed that we needed those services locally. They deregulated all the bulk billing from MRI billing, which is fantastic for anyone, I guess, living in remote Australia.
That's wonderful.
Yeah, and something I'm really proud of, that we were part of that and part of improving primary healthcare.
Have you had any problems with the MRI since it's been installed?
Oh, yes. Well, if there's a power loss, then obviously that chiller unit isn't so effective. So we have put in a sizable generator that used to power a whole mine site previously, and that's great. However, we had one instance where the chiller unit, there was a power outage and the surge did something that I'm not familiar with, but it wasn't great, and the temperature dropped with the MRI. And if the temperature drops to a certain point, we call it the Q word here because it's quench. We don't want to have to quench the unit because it's a very costly process. But so it didn't get down to that point, and we were very lucky that our operations manager's nephew was here till all hours trying to get it going again.
So quenching the unit is when you turn it off, like turn the gas off, and that's expensive process.
Expensive, and it's helium gas that you're putting into the environment, which you really won't. I think this should be probably avoided at all costs. So there's probably environmental ramifications of that as well.
We're sitting in the boardroom now having this chat, and it's beautiful. There's this beautiful wooden table, but talk to me about this building. Just paint a picture of the number of rooms, what's here.
Yeah.
I noticed, for example, I'm pretty sure it was on the RFDS, one of the episodes I was watching, and I was like, I think that's Thrive.
Yeah, it was. Yeah, they came. Actually, there's a funny story about that. So they came and they said, "Can we use your MRI?" And we said, "Yep." I said, "You realise it's a ginormous magnet?" And they're like, "Oh." So they can't. You obviously can't have film equipment near a ginormous magnet, because if you want to, you should YouTube that, because it's terrifying. So that's why we've got all these like, stop, don't go any further if you have a pacemaker or, all these other things.
What happens?
It just like straight up. So it's, phones and
The phones go.
So everything tries to attach to the magnet. So so what they did was they created this big set around the CT, so it looked like an MRI.
Gotcha.
I know, you wouldn't even know, but but there you go. And they actually said, what should we pay you? And I said, no, you can't pay us, because we got one of our staff members actually through the first season that was aired. She watched it, and then we put a job ad out, and she said, I could move to Broken Hill. So I was very grateful for their promotion of Broken Hill, and they said they sort of had to pay us something, so we ended up, but it was more that, what they, I think what that's done for Broken Hill is really, put us on the map in terms of it's the lifestyle here and the beauty of living out here.
We've got off track a little bit.
No,
it was great. But the question was this Thrive building. Yeah, talk me through.
Sorry, Catherine.
That's all right.
Yeah, so it was an old RSL club, and this was the kitchen on this side, and had a big dance floor. So we gutted the whole thing. We found where to put the MRI, because it's obviously very heavy, and there used to be a bowling alley once upon a time in this building. So we so it was already reinforced cement, so that was handy. So we put the MRI on that side of the building also, so we could access it via ambulance if necessary. And then our main building, I guess, is separated into 4 areas. So we have a rehab or a gym area, which we're sort of sitting adjacent to now, and then an allied health sort of wing. And then the front of the building is where you walk in, has the medical consulting rooms, so 7 of those, and then we have an imaging suite. So we have an MRI, CT, X-ray, 2 ultrasounds, mammogram and bone density machine. And then we've got pathology and our NDIS teams at the front of the building as well. So it's a huge space, and I think when we were working on it, the sheer volume of it really, once everything was gutted, it's a massive floor space.
And was it Steve who really encouraged you to kind of go big, like with all these kind of services? So.
Yeah, he actually, and we'd gone the other way. We'd sort of started small and then just gradually tried to find other spots to make people fit. And he said, if you make it big, like you build it and people come.
Has that been true?
Yes, thank goodness. Because it was a big risk and I guess a lot of debt to go into. And he was entirely right. And it's really hard to look to expand if you don't have that space and that room to be able to offer those things. So, it's he's entirely right. And I think he also could see that Broken Hill needed it. Broken Hill needed, someone to really look at what was missing and try and fill those gaps.
Is it used, like, are you fully booked, or what's kind of...
Yeah, yes. So we've closed our books, unfortunately, for medical right at this point in time, which I feel, guilty about on a daily basis. But that being said, I guess we want to be able to, if someone rings up and needs to see a doctor, we want to be able to offer them an appointment in the next week. So if you open your books to everyone, you can't do that for your existing patients. And I feel we have a moral responsibility to be able to do that when people have recalls and they need to be able to get in and see a doctor if they need medication. So I guess we're fully booked with our GPs. Our allied health, we have wait lists for speech pathology, OT, physio, psychology. Physio is actually we're okay with. You can see a physio within that week, but our other services are booked out, and the wait list has been capped. So my wait list is capped at 60, speeches is capped at 30, and I feel guilty about that as well, because the people in our community need these services, and our whole point of being here is to try and fill those gaps. So, yeah, we're certainly working towards it, but we've got a long way to go as well. Our imaging, we usually get people within the week for appointments, but ultrasound has really pushed out, so we've been able to recruit some more staff, so that should alleviate, that need. But that's certainly been, the girls are very busy in there as well.
And it's Thrive opened, I understand, May 2021. Mm-hmm. So what's the future of Thrive and what are the challenges?
Yeah, so I guess the future is pretty exciting, I think, from where we're at right now. So we've got the right people, we've got some processes worked out, which I think when you grow suddenly, that sort of goes by the wayside, and then everyone gets frustrated because there's no clear way of doing things. So I feel like we're at the point where we've caught up to each other. The NDIS space we've experienced a massive growth in that in the last 2 years, and I would love to see us do more and be more creative and innovative and people-centred. So what do people want? How do we, how do we provide that as a service? And I guess what that comes back to is staffing. You can have the best building, but unless you've got the right staff to deliver that service, you don't have much of a business at all. So we've actually just engaged a workforce retention, a lady called Dr. Kathy Cosgrove, who's done her PhD in this, and she's actually going to help us with some strategies on where are our gaps and how do we look to meet them. And I'm really excited about what that next year is going to look like, because and I know we're not alone there. That's the biggest barrier, I think, for most employers in the Far West, is how do we train up people from our own community to meet those gaps, but then also how do we recruit new skills to come into the city.
And let's talk statistics for a moment. What are the health statistics for places like Broken Hill and in outer regions? How do they compare to the city?
Yeah, in terms of health outcomes, poorly. So the RFDS put out a report, I think in 2023, and it looked at the life expectancy for women in remote areas, so we're classified as remote, compared to the rest of Australia. And the life expectancy was significantly less. And if you look at, at why, they're preventable diseases, they're chronic diseases that we're not managing well. And some of that is, I guess, there's lifestyle factors with that. So they looked at smoking, they looked at how much people drink, they looked at how much you exercise throughout the week. But then the other things they looked at is how accessible is the GP for you to see? How many times do you see them per year? And we know that people out here are really disadvantaged in A, the access to a GP, B, the access to the same GP. So. And we call that continuity of care. So if you go back to the same practice, will you see the same person?
And I don't know. I mean, anecdotally, I can speak from my own experience. I don't think I've ever seen the same GP in the 3 or 4 years that I've been here. Mm-hmm. I'm not sure if that's across the board. Mm-hmm. So it's a really difficult problem to solve when it seems like a lot of the GPs are locum GPs. Yeah,
we are really fortunate we have the same locum GPs who keep coming back on a regular, reoccurring basis. That said though, they're not living here. And I think that is the biggest challenge in staffing for GPs that we face. So allied health, not so much. People are quite prepared to move out here. But GPs, I don't think there isn't that model where they used to live and be the town doctor. That's no longer really, it's very hard to recruit that type of doctor. So I think and we'll work with Kath more on this, but I think really what we need to look at is where are these people and how do we adapt what we are offering to make that work so that we can give continuity of care to people. Because I think, that's also goes back to that relationship you have with your GP. If it's someone that you're first seeing, you might go in there and say, I need this referral. If it's your regular doctor, they'll also go, actually, have you had your pap smear done? And what about this? And they'll know you because they'll know if they've done those things with you. A locum's much less likely to do that because they don't have that history with you. So I think that's a big factor as well in those health statistics.
So how do we move away from the locum model? Obviously attracting GPs, but how do we attract them?
Yeah, that's really interesting. So Kath's research is called Attract, Connect and Stay, and it looks at, so not just as, how does Thrive do it, but how do we as a whole community do it? So they look at the model of having a community connector. So someone who, say the person who moves here, their husband can't find a job in this area, or they can't get childcare, or, housing's an issue. So how do we look at solutions to those problems so that we can attract people to move here? Because you hear that often, I wanted to move but I couldn't get childcare, or I wanted to do this but there were no rentals in that area. So how do we look at addressing those problems for people so they want to come and live here?
What reforms do you think needs to happen at a broader level?
That's a really good point. So I guess if we are reliant on a locum model, then we have to pay locums significantly to be able to afford them. What we have here is we do a mixed billing model. So we have some people we bulk bill, but predominantly we pay, people have to pay a gap, which is, there's a whole trend across Australia which is pushing towards that. I think the issue in remote areas is we're having to pay more for GPs to come out here, and there's a big gap between what the revenue that we're bringing in through Medicare and mixed billings and what we're having to pay out. So for an example, last year the medical part of our business ran a loss because we're having to pay them more than what Medicare are providing us with revenue for. So I think there's a huge need to look at remote areas and say, do we need to have an increased levy on those rates so that it's comparable to what people would be paying in metro areas for locums? Because I think that's
so the Medicare levy is not different for a regional area.
No, and you look at, for example, NDIS. There's a 40% loading, in Broken Hill that we get because we're in a remote area, and what that does is it allows us to be able to pay people more. And that's why we have been able to recruit allied health specialists, and we have been able to provide them with accommodation and assist getting them set up and provide childcare, because we've got a bit more of a buffer to play with. If you did that in the Medicare space, it would make a huge difference. So I think there needs to be reforms at that level.
And the other comment that I've heard is that when it comes to Medicare, that you can only kind of bill on face-to-face time, and it doesn't account for all of the kind of time outside of that.
Yes, absolutely.
That doctors need to do reports or get referrals and information. So
that's right.
Would you have a comment on that as well?
Yeah, there is so much time, and I think until you've really seen what goes into comprehensive care of patient care, that isn't when the patient's sitting there in that seat. It's behind the scenes. It's checking on results. It's ringing them. It's having a chat to the pharmacist about the dosage of the medication. It's having a chat to their physio. Are they progressing? Are they not? And that's not billable through Medicare. So if we're looking at providing better primary health care, we really need to be including capturing that into how GPs are funded.
You mentioned earlier that it's easier to attract allied health services to Broken Hill than GPs, but I know that we need allied health workers, and just to use myself as a bit of an example, last year I got NDIS early intervention funding for my 3.5-year-old son. The process of getting the funding was really good actually, but trying to find therapy services, I knew that would be hard. I was told the only option for me for OT or speech pathology, which was what was recommended for us, was to go to this fly-in, fly-out service from Adelaide, and they were coming to Broken Hill once a fortnight, doing an hour therapy and then flying home and seeing lots of other patients in Broken Hill. So I started that towards the end of last year. We had 3 months, and then the start of this year I get a phone call from them saying, sorry, we have to change your OT. And that was really frustrating for me because we'd only just got to the point where I felt like we were starting to actually make some progress, or the OT was getting to know my son and vice versa, feeling comfortable with her. And so I felt like I was going back to the beginning. But then also from a financial point of view, and it's not paid by me, it's paid by the taxpayer. But this group charges $270 for the therapy, which is, I guess, the standard amount, and then I was charged $270 for a travel component. So $540 for a 1 hour therapy session, and that's obviously happening with lots of other people in Broken Hill. And interestingly, I note that this business posted on Facebook today actually that they were looking for a space in Broken Hill, and they have 9 clinicians that come here once a fortnight, and they were looking to increase that to weekly. So such is the demand. But I just think, how is this sustainable? Why can't we get more allied health professionals who live here? Because I'm also frustrated by the fact that there could be quite high turnover. Like, I could have another OT and then it change again. Thankfully, I do have a new OT locally, but that's not going to be everyone's experience. And the other thing, that parents don't really have any choice about what service they get. They'll just take whatever they can get. So do you have any comment on that?
Absolutely. I have a lot to comment on that. There are so many parts of that. So first of all, workforce recruitment and retention should be our number one focus, I think, for allied health. It certainly is in our strategic plan. The issues, I think, that we're facing around that is, there are so many jobs out there, and, I can't comment on this company, but there's a lot of people that are in there just because they can see the money-making side of it, and, they aren't providing good clinical supervision. They're throwing them into positions where they, don't necessarily have the training or the experience to do the full components of the job that they're doing. And the burnout rate in OT, I've been in OT for over 20 years now, and I love my job. I think I'll be in OT for the rest of my life. But they're turning people off of the industry because it's turned into this, money-making exercise. And the only way I think we really need to refocus how people think about remote health. So it's certainly seen as something you do at the start of your career, and then you move somewhere else that you want to live, and you don't really have to go back and do that again. And I think it's the opposite. I think it's the most rewarding thing I have done is to have a career in Broken Hill, and why it's satisfying is you're helping people who can't access those services otherwise. It's diverse, like the problem solving, and you have to be resourceful, you have to think outside the box. Those skills set you up for anything you want to do for the rest of your life. So I really think we need to somehow tweak university courses so that people get that exposure to this is what rural practice looks like. There's certainly police, education, they have components of their time which has to be in the country. That's how my mum met my dad, actually. She got sent out to one of those places with about 10 kids, and they had the welcome the teacher barbecue. No, there were about 100 kids, and she met my dad. But I guess we need to change how rural practice is perceived, but you also need to change it for families, because they're not able to access the services, they're not getting early intervention. And then just going back to, I guess, the conversations that you've had with Jane on things like literacy levels and cognition. When kids are starting school, they're delayed, and they're delayed because they're not getting access to the services that we need. And personally, I don't think we fix it by a fly in fly out model. I think we fix it from the ground up with making people want to go on to study at a university level locally, and then come back to live in that community. So I think there's lots that needs to be done, but I think if we're just expecting people to move out here, I think we're only capturing a little bit of the population. I think we need to be changing our whole focus of the town, that have dreams, have goals, aspire to be whatever you want to be, and maybe hopefully that's an occupational therapist or a speech therapist.
So you're saying about trying to encourage people who are born and bred Broken Hill people to consider occupational therapy as a career?
I think people are much more likely to come back to regional areas if they've had that exposure. And I know I didn't grow up here, but I did grow up in in that town that I just spoke of. That, you know, I was familiar with small communities, and I loved that. So that made me, I think, fit in really well here.
And just to go back a step, I note before that you're using childcare as an example of how we need to support people to move to town, and you've kind of spearheaded a new way of handling childcare for Thrive. Can you tell me about that?
I'd love to tell you about that. So Phoebe, who when I said we had, you know, started with one OT and then went to two. Phoebe was the very first person I employed. So we worked really closely together. Phoebe fell in love with Mick, and Mick's from Broken Hill and Phoebe wasn't. And then Phoebe was keen to get out of Broken Hill, so they moved to Wagga Wagga, and she was like, yes, I've finally got him out of Broken Hill. Anyway, then Mick changed careers, and he was a plumber, and then he wanted to be a livestock agent, so he did a traineeship with elders. And so when he completed that, they said to him, oh, we've got a job for you, it's in Broken Hill. So Phoebe's like, no, I've just got him out. And I was rejoicing because I've got this huge wait list, Phoebe, you can help me. And she came back and she said to Heather, I would, but I have to wait 2 years to get Winnie, her daughter, into childcare. And I said, that's ridiculous. We can fix that. It's got to be easier to get childcare than it is to find another OT. So I contacted Amanda Peterson, who had looked after my children when they were very young, and also has been really important in allowing me to have the, I guess, career progression that I have, is the support that I had around me. So Amanda, my parents, extended family have all, really contributed to that. So I said to Amanda, what about it? Her youngest daughter just started school. And Amanda was like, oh, okay. So it started in my house. And then within 3 months, we had 5 children between Monday and Thursday of people who wanted to come back into the workforce but couldn't because they couldn't get childcare. So we found a clinical psychologist that way. We had our admin team who could have worked more days, but they couldn't because they couldn't have childcare. We had support workers. So it really, for us, we looked at, and I remember suggesting this to the accountant, and they looked at me like I had two heads. But I was like, you try being a young mum. It's very hard. It's it's isolating in terms of you can't get both your children in one day. You actually can't commit to going back to work. So you're out of the workforce when you don't need to be. And if we can't get those people from within our own community, we're going to have to fly people in, and you're looking at locum rates are more expensive, you're looking at flights, accommodation. The cost of childcare per hour compared to what a locum model is so much better for an organisation financially, and also, I guess, for me, I think what guides a lot of my decision making is remembering what it was like to be a young mum and going through that process, and what would I do if that was my dad, or what would I do if that was my brother who was in that position. And that's, I guess, how I think about healthcare. Like, what would I do for that person if they were in my immediate family? And I think that's such an important thing for us to focus on when our workforce is primarily made up of young women. So how do we help them? And this was a really practical way that we could.
And it's so great that you had the capacity to do that too, and to kind of pull on your network of people to create that. I mean, it'd be great if more businesses could do that, but also understand that they're also holding a lot of pressures to do that. But, I think childcare is a big one to solve. Absolutely,
especially, in areas, and I know we're not alone of having this issue. And I think you have to have people around you who are willing to run with crazy ideas sometimes. So, my son was at boarding school when I turned his room into the childcare facility, and he came home and he's like, "Mum, what's happened?" Sorry, cameraman. But and he's an amazing kid. So, I think if you can you can think outside the box, and I think that's really, as employers, what we need to do. You need to go, what are our barriers, and how do we help? If we overcome this barrier, how's it going to solve our problem, and is that worth it? And for us, it's definitely been worth it.
You've been in Broken Hill now for, 13, 14 years?
Yes.
What's kept you here?
Yeah, that's a great question. I think it's this network of people around you that, if your child's stuck at footy or if you're stuck in a meeting and you can say, can you pick Harry up or can you drop Zoe here? And they just, respond with no worries. So I think it's those networks, those relationships. My parents are here and they've been amazing support. And I guess the relationship that they've had with my children as well. But I love that, that there's a generational aspect of bringing up children that I've had because we're all in the same town. And I think, that's personally, but I think professionally, there's so many opportunities in areas like these if people are prepared to move outside of the city and give it a go. And I guess for me, sometimes, I think, would I have had these opportunities if I was in Adelaide? Would it have been this, would I have been so fortunate? And I don't know if I would have because, Steve often says that. He said, Broken Hill, you can be whoever you want to be here. You can make it whatever you want to make it. And to be honest, for me, that took a while in Broken Hill because I wasn't from here and it took a while for people to be able to trust me. But I think he's right in that it's one of those towns that there's a huge amount of need, so that if you can be creative in what you're doing and how you're doing it, there is a great potential to build something.
What does it take to break into the town?
Yeah, that's interesting. And I think if you think of that, and there's no maliciousness there. People don't want, like, they're just protective and they're loyal. So I think if you can understand that and you can understand why they're feeling like that, and you can be patient with the process of developing relationships and building trust, then that's sort of the point where things tip. And I guess for me, because Steve, saw potential in me, that, Steve was a well-known member of the Broken Hill community, so that I probably got there by association a little bit. But I think also people in Broken Hill, if you do show that you really want to help improve things, that they can see that as well. But it just does take some time.
Well, Heather, it's been such a privilege to talk to you and to hear the story of Thrive and your own professional journey. And I just wanted to say, is there anything else you wanted to say before we concluded our chat today?
No, thank you very much.
That was Heather Pearce, an occupational therapist and CEO of Thrive Medical in Broken Hill. You've been listening to A Home in the Outback, an independent podcast about people living, working and creating in the far west of New South Wales.